morning, good afternoon, and good evening. Our global cafe this morning needs to matter. It needs to matter because a good colleague and friend of both Seth and myself and many hundreds of thousands, if not millions of people, passed away not 2 days ago. I first met Kawaldip Semi in a coffee shop in London. Kawaldip was the CEO of the International Association of Patient Organisations. Kawaldip was one of those characters that left an indelible mark on my work and who I am, because he was open to opportunities, he was knowledgeable. He had a Rolodex bigger than all of us put together. He was kind and gentle, and he shared ideas and information unconditionally. And it's important to stop and recognise not only the contribution of people like Kawaldip, but who Kawaldip is and was to our community. And so while we start off on a somber note in noting the passing of Kawaldip Semi, it is also an opening to just put on the table that advocacy and advocates, have really influenced policy and changed the lives of people around the world. So thank you for the indulgence of sharing that with you. And I have to thank Seth because I just shared that news with him not 5 minutes ago. So I'm going to let Seth sort of gain some breath. But Seth is also one of those advocates. Education and advocacy is at the heart of improving the health and well-being of people all over the world. So when I met Seth, just like I met Kawaldip, where planets aligned somehow, it was at a meeting in Washington, and we are part of the Brains Trust. But Seth is engaging, innovative, inspiring, almost contagious in his passion, and almost the same in terms of his sharing of ideas. He's an international health advocate and a global thought leader. In his day job and probably in his night job too, he's the president and co-founder of the Global Health Living Foundation. Seth helped pioneer the world's first online patient community for the millions of people worldwide suffering from arthritis, and it's called Creaky Joints. What a great name. It has now grown into a trusted and recognised patient community, delivering robust education, community-based and web-based support, advocacy initiatives and patient-centred research to patients all around the world. So if you don't know about Creaky Joints, find out and be part of it. Seth also helped, as you can imagine, the Global Health Living Foundation's 50-state network across the United States. And it's a very active network of more than 1,800 patient advocates that focus on barriers to care for people living with chronic diseases. He's represented, many organisations and the people that he stands for at Congress and health-related congressional committees and caucuses, and also at the US Department of Health and Human Services and its regulatory agency, the Food and Drug Administration. Just out of that one meeting with Seth some time ago in Washington, he decided to come to IFA's global conference. And that demonstrates to me the kind of commitment of the person that I'm going to be in conversation with today. So Seth, thank you for being with us today. to talk about who you are and what you do and what your vision is, but also on this special day for us.
Thanks, Jane. And I'm reminded of the Bette Midler quote, all right, enough about me, let's talk about you. What do you think of me? I want to actually begin a lot more sober than that on the heels of this news I got about 7 minutes ago, and want to dedicate this conversation. And in fact, everything all of us are going to do today in our lives and in our jobs and in our work to help other people to Kowal in his memory. And you know, as a member of IAPA, of course, and as a colleague and someone, I wasn't very personally close to him, but you know, news like this is just the starkest reminder that life is very fragile, and you know, tomorrow is not promised to anyone, and we need to really make the most of today. So here's to this dedication to Kowal and his family and his colleagues, and really the global patient advocacy community, which today is absolutely in mourning, and really just a little startled by it all. So here's to that. But let's in the spirit of honoring great people doing great things, let's make this a conversation that is interesting, that could be fun at times, and that hopefully brightens all of our day a little bit, despite that news just now, as we go forth and as we conquer our own domains in the work that we do. I'm very pleased to be here. It's really an honor. I've really enjoyed getting to know you, Jane. It's been a real privilege. You maintain my undefeated streak of all these years of not once meeting an Aussie I didn't like. In saying that, you know, I've had the privilege, as you mentioned, to visit and to participate in the global conference last month in Bangkok, where I did have the opportunity not just to meet the wonderful team and staff at IFA, but also so many important delegates, so many important stakeholders, just an absolute cacophony of amazing humans from many different sectors convening for this important gathering. And it did three things for me. One, it endeared me probably forever, for sure, to IFA. Two, it motivated me to continue Global Healthy Living Foundation's global expansion, recognizing all of these places around the world and their unique issues and challenges facing patients, especially aging patients. And three, it brought me to Bangkok, which was really cool and interesting, and a place that I'd never been before, in Thailand, and to learn, as I usually geek out on these trips, about the history of Thailand, but also the geopolitical status of Thailand and its real up and coming nature in the Southeast Asian, Indochine region. Was really neat, and something I don't think I would have appreciated had I participated remotely. So we're going to make the most of this hour. As you could tell, I've had that second. My joke is, you know, today's conversation is sponsored by espresso, and the 2 cups of it that I had before this discussion. But my aim is to not do all the talking, and to listen to folks and what's on their mind and what's on you'd like to talk about, and maybe answer some questions and take it from there.
Look, thanks very much, Seth. I want to start off with telemedicine, telehealth. And, you know, you were the principal investigator in the development of a smartphone app called Arthritis Power, which has been engineered for and by people with autoimmune and inflammatory conditions. You know, telemedicine is more than just a cheap digital knockoff, isn't it? But I just want to hear from you what Arthritis Power has really done for people with autoimmune and inflammatory conditions. And you might want to start off by just a quick definition on what do we mean by autoimmune conditions?
Sure. Okay, awesome. So let's take half a step further back and just paint the picture here. So I've been living with arthritis since I was 13. Was diagnosed with spondyloarthropathy. As you mentioned, started Creaky Joints, this online patient community, from a dorm room bunk bed 25 years ago, literally the first online community for rheumatic diseases in the world. It has done nothing but grow and thrive in all these years, with millions and millions of patients that have come through for education, for support, to become empowered. And about 10 years ago, we turned a corner thanks to the Patient-Centered Outcomes Research Institute, PCORI. This was about a $3 billion trust fund created by the Affordable Care Act, or Obamacare, to invest in the creation of comparative effectiveness research infrastructure. I know I'm using a lot of big words here all at once, but basically, we were contacted by a friend and colleague that said, I think they wrote this for you all because they're giving money to groups that don't have research capacity, but should have research capacity. And lo and behold, we were awarded that first contract and subsequent several others since then. And what we created with it was this Arthritis Power patient registry. It's a mobile app, a smartphone app, and a web app that collects patient-reported outcomes for people with inflammatory autoimmune diseases. These are conditions like rheumatoid arthritis, psoriatic arthritis, and now psoriasis, Crohn's disease. Any condition where the immune system mistakes itself, the body, and attacks itself and causes usually painful inflammation and several other risk factors. And we created this registry where people consent to participate. But we really, that was like what we did on the first day. What we did on the second day and all the time through then was enable patients to have a different and better relationship with their condition and empower patients to have a more meaningful and more substantial conversation with their physicians. When you go to the doctor with a systemic autoimmune disease like RA, you're seeing this person maybe 4 times a year for quarterly checkups. You're answering a health questionnaire in that waiting room about how you're feeling, how you're doing. And it typically refers to how you're doing yesterday and today, right? But there are 87 or 88 other days between those visits that aren't adequately captured. That's the spirit of what Arthritis Power is all about. And as we engineer it further, giving patients real-time, personal, and accessible information about their condition based on those patient-reported outcomes means Arthritis Power is growing and learning and using technology like AI and machine learning to give patients the information they need based on the patient-reported outcomes that they're logging. And then the last thing I'll say, and kind of cool about it all, is we actually just finalized our plans to change the name. We're going through a 10-year rebrand, and we'll be calling it Patient Power, because with now close to 50,000 patients using this app regularly, and new tools like remote therapeutic monitoring and remote patient monitoring, where this information is literally synced and ported right to your clinician and into your medical records, we realized that calling it Arthritis Power did a massive disservice to basically everyone that doesn't have arthritis. They might have a condition like lupus. They might have a condition like psoriasis. And so Patient Power is facilitating the patient's relationship with their condition with tools and with resources that are all about that individual. Now, the last thing I'll say on this topic is it's not, it is a tangential line to telemedicine. That's almost like a horse of a different color, in the sense that telemedicine and virtual care, especially in the COVID and post-COVID era, is completely different than it was prior to now. We're more connected. There's this digital infrastructure that exists in most of the developed world. I recognize there are health inequities and access to technology that prevent people from being online. We're working on that too. But just as cholera gave us indoor plumbing back in the day, our hope is a pandemic like COVID is going to give us a normalized and system embraced virtual care telemedicine system, but we're hopeful for that, at least.
Seth, you've said a couple of times the relationship with your condition, and I've never heard that phrase, and I think it's an important one to actually to return to. And I want to just ask you a question about Patient Power. So this is real time, is it? You know, you're putting data in. Explain to me, if I have psoriasis, what do I need to do to engage in this community?
Right. So, okay. So what we do is we use standard domains, standard instruments from the National Institute of Health called the PROMIS measures. These are the patient reported outcome measurement instruments. So it's a very standardized data set that when patients log how they're doing, the instruments are uniformed across patients and other domains. And secondly, what you're doing, to the individual you invoke, is you're logging how you're feeling, you're logging how psoriasis is impacting your disease. You're going beyond the physical exam, basically. And you're providing perspective to the tool using these instruments about, say, your mood, and what your mental health status is, your physical function and your activity set, and what else kind of comes in the way of happiness and living a fulfilling life. And that allows for the much more effective discussion with the doctor, which we all know is limited to about 90 seconds these days, and that's almost not an exaggeration. But it allows for the much more qualitative and much more quantified capture of how you're doing as a patient from your perspective, which I think is very, very powerful to put patients on that level footing as their clinicians. Too often there's a discordance rather in both communication, in perspective. Anything in an electronic medical record, if not everything in an electronic medical record, is about the patient through the eyes and the ears and the interpretation of the doctor or nurse entering it. So it is inherently biased toward that professional's impressions and or interpretations. So giving patients the ability to literally log their perspective into that medical record or into that clinical discussion is incredibly powerful. And that's why we named it Patient Power.
Yeah. What a great name. Seth, I'm just going to go to Shmuel and ask his question. Shmuel is a devotee, and thank you, Shmuel, for being with us every single day. And he's really talking about, how can education support improvement in quality care for older people in low and middle income countries? So are you venturing, you said that you are expanding, to what degree can we hope for in the future expansion of, the foundation into low and middle income countries?
This is a huge area of discussion and a major topic for us at GHLF, because a lot of what we want to do is continue essentially the exportation of our unique brand of patient advocacy to countries and regions and populations that would never otherwise be exposed to it. This notion of empowerment is one that is also very interpretive and also, I think, very relative to who and where and when, right? And how. We're talking about the 21st century. Imagine, what this conversation would be like 50, 100, 200 years ago. We definitely wouldn't be having it on Zoom. And so with respect to these low socioeconomic groups and these populations with huge gaps in care and unmet needs, a lot of it is cultural, and a lot of it has to do with ways that we can allow for populations to view healthcare, view personal health initiatives culturally in a favorable light. We recognize that we are, not the people to necessarily change cultures in any respect, but at the same time, if we could look at, the cultural phenomenon, and that's probably not the right word, of too many places. Let's pick Nepal, for example, where a young girl who gets her period is with shame not going to school for a whole week. And that's 1 week out of every month. This young lady in a prime age for learning and development is culturally not comfortable or permitted, or culturally not accepted to be a part of day-to-day society. That's what I mean when I talk about the cultural barriers, which are arguably far stronger and far more substantial than these geopolitical, systemic, even geographic barriers that exist between people. So when we look at through the lens of culture, we become even more sensitive to the challenges that we face in addressing these populations.
And we talk too little about these lenses through which we look at policy. We often talk about gender lens and cultural lens. And so it's about making sure, and through that app, it's very clear that that lens is central to the discussions between the patient and the doctor. We've got another couple of questions. So I'm going to invite Yagana Imam. Yagana, are you with us today?
Yeah, thank you for giving me the opportunity. Good morning, good afternoon. My question is concerning the age of the patients. Are they considering arthritis due to young ages or cuts across all ages? Because arthritis can affect young ones and elderly.
Absolutely.
Number two, the second question is, we are talking of autoimmune diseases. Are you considering arthritis only due to autoimmune diseases or due to other conditions like trauma, any other things that can cause arthritis?
Excellent questions, thanks. So first of all, having now turned into this 25th year, believe it or not, of doing this, it's been apparent how the populations that are online are significantly older than they were in the beginning when we started, significantly older. And old is the new young, I guess you could say, right? Like just, 70 is the new 50 and 80 is the new 60, that kind of concept. So the mindset of older populations is significantly younger than it used to be 25 years ago. So our reach and our population actually skews a bit older than it used to by, extension of the fact that the largest age demographic of people active on Facebook, for example, are over 55. And that's one of the domains where we're quite popular. But the question about arthritis is a great one. So there's obviously two kinds of arthritis, two major kinds. There's the degenerative joint disease, which is your osteoarthritis, which is what happens when we all get older. Our joints deteriorate after, 50, 60, 70, 80 years of hitting the pavement every day with our ankles and hips and knees. And then there's autoimmune or inflammatory arthritis, and these are the conditions like rheumatoid arthritis and psoriatic arthritis. And this is a systemic, whole body condition that actually affects younger populations, people, predominantly women in their 30s, 40s, and 50s. Some kids do get it as well, of course. So when we talk about autoimmune conditions, but when we also talk about degenerative joint disease, we love talking about it, as you mentioned, in the context of co-conditions. We learned very early, no one just has arthritis, no one. Most people don't just have one condition. They're battling 2, sometimes 3 different diseases. Sometimes they're related, most often they're not. And if they're not personally managing a second or third disease, their partner is, their son or daughter might be, their parents certainly could be. And so when we talk about rheumatic diseases, musculoskeletal conditions, autoimmune diseases, we almost never talk about it in a silo or in the individual sense. It's almost always talked about in the context of the larger healthy living context for people to understand that they have to manage their health in general, kind of writ large, and that might be with rheumatoid arthritis as well as Crohn's disease, or that might be with asthma as well as atopic dermatitis or eczema. And so allowing people to see themselves as an N of one, because they really are a unique population with those different types of conditions, has given us, I think, a lot of stickiness, and has given patients a great affinity for what we're doing, because it's certainly more personalized.
Thank you, Seth. I'm also now going to ask Nalika Padmasena. Nalika, are you with us? And come forward and ask your question to Seth.
Hi, sorry. Well, I think you already started explaining about this, but I thought, because of the, when you're talking about communication and the perspectives, sometimes like the cultural diversity and also the cultural beliefs prevent people from looking into the new technologies and new teaching. So, sometimes some health conditions are based on demonizing the very primitive cultural beliefs. So what are the challenges in taking this further? And because that depends on the poor education, the poor economic status as well. So that's
Sure.
a huge challenge. Thank you.
Yeah, if I don't mean to make light of it, but we have a saying at GHLF that if this were easy, everyone would be doing it. So you're opening up a proper can of worms, and I guess I could speak to that with some very personal and literal experience. A number of years ago, GHLF was producing these healthy living forums, community-based events where we would gather communities together and expose them and facilitate discussions with healthcare providers, advanced practice providers, nutritionists, things like that. And health psychologists was a big one. And then, the free medications and free access to care programs. It was all about kind of bringing people together in a positive environment and giving them, pathways to get the services that they just needed, that last, mile connection to how to get the medicine, how to get the care. Anyway, we did these in New York City, and we did a series, dozens of them, but I remember doing them in English. I remember doing them in Spanish. I remember doing them in Russian. I remember doing them in Mandarin. I remember doing them in Korean. And I remember the stark differences in these communities' engagement levels, in their receptivity to the messages. And it gave us a on-the-ground view, and this is just in the 5 boroughs of New York City, but these were all, proper Flushing, Queens, Chinese program, or Jackson Heights in Russian, and et cetera. But it gave us a really literal view of the vast differences in how cultures think about health, respond to healthy living discussions, and engage around health. And it showed us the intrinsic challenges that we face here in the US, but let alone everywhere else, in addressing these concerns with these individual populations. And the answer, it's not an easy one, and we certainly don't hold that magic bullet, but as I've been saying, it's not as simple as saying, here, work for them, it's gonna work for you. We know this. It's about the nuance. It's about the personalization that enables people to individually connect. We're running this awesome program up in the far north through Alaska, and we're talking to indigenous patients, right? Through the Indian Health Service federal government program, in partnership with a number of native, indigenous, tribal groups, and healthcare providers. And I can't think of a more proper example of how it does not translate. than talking about, you know, autoimmune and systemic and inflammatory diseases within indigenous population of native Alaskan regional patients compared to, you know, Russian speaking patients in Jackson Heights, Queens. So for us, the challenge has been, you know, addressing these concerns in a thoughtful and productive manner, and also not like driving ourselves, you know, off a cliff, because at the end of the day, we can't do everything for everybody. So we have to kind of deliberately pick and choose strategically how we're going to help, who we're going to help, when we're going to help them, and where.
And of course, Seth, you know, we're always talking about, you know, the investment in health promotion and prevention. And I think that, you know, both our organizations, you know, call for governments to actually shift from the curative model, you know, to the prevention model, you know, which is really fundamental to health system change. I'm going to, Seth, ask Peggy Hawthorne to come forward to ask her question, and then Emmanuel Kastranakis. Emmanuel, could you put your question in the chat box? That would be really helpful. So Peggy Hawthorne.
Yes, thank you. My question is basically focused around the fact that this is I think an excellent tool, and really helps that communication and linkage between the patient and doctor. But I know in our situation here in Canada, and I'm sure it's, you know, the states are facing the same situation, are shortages of physicians, nurse practitioners, you know, other primary care physicians. And it sounds as this app is the link between the patient and their primary care physician. Where patients are seeing walk-in doctors or using an emergency department as their primary care, you know, provider, how can this app be used, and, you know, is it as effective as if you had a primary care provider?
Certainly, it wouldn't replace primary care. And, you know, a lot of what GHLF, it's a great question, by the way, thank you, Peggy, because we spent a lot of time thinking about this, actually spent most of yesterday working through some potential solutions for the workforce shortage of specialty care. I mean, there are just no specialists. They're retiring at a much greater clip than they're joining the ranks, especially in rheumatology, but across a number of specialties. And that's just specialty care. This primary care is an equally large challenge. And here's the thing, GHLF, we're not going to be everyone's solution. We can't be. We're just some nonprofit that some kids started from a dorm room, albeit we've grown quite a bit. It's the institutional power that exists in developed countries, especially in first world nations like yours and mine, who need to come to the table and appreciate the importance and the necessity for not just survival, but for thriving of a healthier population. And when that happens, with cheerleading, with acceleration, and hopefully with GHLF as a catalyst, one of many catalysts for this to occur, when that happens, and when governments, and when in the US, for example, all the capitalists involved in our US healthcare system all recognize that if we don't make investments in bridging the doctor and provider gaps, in facilitating the remote management of most chronic illnesses, in tools that can triage care in efficient, effective, cost-effective ways. I mean, these are the things that the big boys and girls have to come to the table and make the proper investment in, so that we view, and this has always been my dream, that we view healthcare in the same light as we view defense. And let me explain that. We, at least in the US, and I'll speak for most of our allied countries, when we look at our national defense budgets, when we look at what those budgets go toward, it's for one thing, it's for military readiness, is to have the best and the coolest and the most destructive missiles and weapons and so forth, lasers and you name it. Why aren't we as a society using that exact same mindset for our healthcare? Why aren't we thinking about defense in the same vein as we are healthcare? Because they ought to be in the same spirit of we want the best, we want the most, we want and need and deserve the premium. And so, you know, we got a long ways to go. Our Thrice Power, you know, and our partners, whether they're life science companies, technology companies, or elsewhere, you know, is an excellent example, but is not necessarily the solution for bridging patients in primary care. But hopefully, as I said, the catalyst for that occurring in the future.
Yeah, it seems to me that, you know, this app, you know, has a lot of capacity for us to think about the interrelationship between an older person and long-term care also. Yet it seems to me that we're just missing that piece constantly. Your thoughts on that?
This is the case. And, you know, I think too, what we want to do is we want to create, I'm sorry, I've got a toddler here whose Cheerios have run out, excuse me. What we'd like to do is create, the avenue for technology to address these challenges.
Yeah. And
the Googles of the world, the Amazons of the world, these are the institutional powers I was referring to, you know, replace Lockheed Martin, I guess, with Amazon. That's a scary thought, I know. But these are the companies that overnight could put a device smaller than this in everybody's home, in everybody's domain, that's got the satellites that are already connected to it, that could easily keep effective tabs on older populations in what I only hope and pray. And again, this is our job. What I only aspire to be a benevolent reason for the care and management with dignity of that human being. And I will just say this in as, you know, guarded a negative way possible. There's no way Amazon's waking up to put a device in everyone's home for a benevolent reason. Like, it doesn't work that way. However, with the right political capital, the right societal will, and the right kind of general population desire, I do think technology is going to continue the arc of supporting our evolution. And again, we're just one little cog in that wheel, leading hopefully by example, but the big kids will step in eventually.
And also we need to come forward and partner with you. You know, IFA and GHLF, you know, are ruminating about how best to work. And by the way, we love toddlers with or without Cheerios. So we welcome them to the table. What's your toddler's name?
This is Teddy. He's over there, but yeah, I promised him no cameos today.
Well, we welcome Teddy. Emmanuel Kastronakis. Emmanuel, you've been waiting a long time and you're from Greece, coming from Greece. Could you come forward and share your question with Seth?
Yes, thank you very much. I should introduce myself. I'm a new member of IFA. I'm quite enthusiastic with the 3 already presentations that I participated. And I should say that our organization, which is called 50 Plus, deals with, among other things, so the human rights of older people, in other words, above 50, not that they are the older ones, but above 50 we chose. And at this stage in time, one of the priorities of the Greek government is to modify the whole public system, health public system. And therefore, we want to help primarily in the area of prevention and the anthropocentric care, to use some Greek words. Now, my question is a 3-part, but they're all aimed at the same point. In other words, how can we attract people? Let's say, I should say also that we're cooperating with the University of Thessaloniki, which is doing a great job in combining technology with health. And of course, the majority of the applications are in favor and benefit of older people, in other words, above 50 or 60. Now, the question is, how can we attract people to participate in a pilot scheme that Mr. Ginsberg is proposing in Greece, of course, in the Greek language? What will be the benefit of the person who participates and presents his case as he describes to particular people who will write down what the patient is declaring? And finally, how can we take the results of this effort and combine them with the central results of the NGO that Mr. Ginsberg represents, for which this work will provide better answers with AI systems and whatever other technical solutions, so that we can eventually come up with proper tools and remedies for the particular area, let's say, of rheumatoid arthritis or any particular area we choose.
Thank you, Emmanuel. Go, Seth.
Yeah, no, this is what I love, because I spent yesterday thinking about workforce shortage, and I'm thinking about today user engagement, basically is what we call it, right? And here's the problem. And we learned this a long time ago, but boy, it's more stark than ever. Getting people to lean in to their health is easily one of the hardest things to do. If you're unhealthy, if you've got chronic diseases, the last thing you want to be told is you got to lose 20 pounds, you got to eat differently, you got to do this, you got to do that. And if you're healthy, the last thing you want to be reminded of is the potential to get sick. So we have this like challenge where it's like, how do we engage with patients and their families in meaningful ways? And one of the avenues we've been exploring is through this notion of positive reinforcement that does release the endorphins, and does get us a little dopamine hit, the way, Facebook invented that like button. And gosh, it makes you feel good when you get something liked. Hence, you're back on the site. Hence, you're liking other people's stuff. And marrying that positive reinforcement with this sense of personal responsibility. Again, this comes back to that cultural shift where we have to think about how each culture, and not only do they vary country by country, but obviously region by region and socioeconomic group by socioeconomic group, how do we give people a sense of personal responsibility that empowers them to lean into their health, to lean into more information that will then translate into better informed decisions, that will then translate to more specific actions taken, that will then translate to hopefully healthier outcomes. Talking about attitudes, beliefs, and behaviors, and trying to change those three things across all these different cultures and population and phenotypes, again, it's like some of the hardest stuff in the world. And I want to give us all credit for thinking and talking and working on these things, realizing that there's no easy solution, and yet we can't be deterred and must continue to take a run at this. So with respect to Greece, a country we fondly love, by the way, and most, I would say, European countries or otherwise socialized medicine societies, I think you at least have a head start. You at least have, and I'll take, Australia as an example, as a society that has baked into it this notion that you're in the healthcare system from birth, from cradle to grave, and from all stages and all walks of life, we're all in this together. Very different in the US. It's the carved out, dysfunctional healthcare system in the world. I'll be the first to admit that publicly. But for socialized medicine countries and societies, you know, you have a head start in giving older adults and, you know, older populations the benefit of needing to understand, you know, their role and the options they have to age with dignity, to address their aging chronic illnesses in ways that hopefully serve themselves, but also, you know, society writ large. So I think that there's no easy answer to that incredibly sophisticated question and thought that you bring to the table, but something that the answer is in primary care and in advanced practice providers, those what we'd say lowest hanging fruit of the healthcare system for patients to access. And hopefully, God willing, technology is there to address these challenges, you know, at scale, essentially.
Thanks, Seth, and thank you very much, Emmanuel, for joining the IFA, being with us, and may it continue, and perhaps we can have another conversation. You know, we fondly had Dr. Elizabeth Mestheninos on our board for many years, so we welcome that. I'm going to change tack a little bit, Seth. We met at the Brains Trust, and that was all about vaccination. So what role did GHLF play during the pandemic to get messages out to the communities that you serve? And what was the success of that or not? What did we learn from your perspective?
Well, we learn a lot. You know, we learn that communities are all, I think, intrinsically different. And, you know, for us, one of the biggest opportunities is to remove people's identity from being, I have X disease, and into being, I'm a person and I live with health conditions, as do most other people. And giving people that identity shift, I think, allows for a much more fulfilling and more authentic engagement. But it's just one of, I think, many different challenges that get uncovered, you know, in intrinsic to like this at scale growth, where, golly, and I know, I guess this is a repetitive theme of today, isn't it? That it's not easy. But it's complicated, and I think it deserves our full attention.
So just in taking that, knowing that vaccination is one of the most effective public health interventions of our time, I just want to now move into our healthcare systems. And we've already mentioned that, you know, our healthcare systems are really under siege, you know, from the pandemic, but also pre-pandemic. You know, there was a lot of disconnectedness, and people with a number of conditions, you know, find the pathways, you know, very confusing and not connected. What are the policy levers that GHLF use? You know, you've talked about workforce that you've been looking at, and you've talked about people-centered approaches. And so, you know, if there were 3 policy levers that you actually focused on, what would they be?
Well, okay, great question, and I don't mean to shortchange that discussion and this discussion around vaccinations, which is, you know, easily one of the most important topics in vaccine preventable illnesses in the 21st century, 22nd century, or whatever year we're living in now, are, you know, indicative of the advancement of life science technology, and it's like humanity's failure to bring these technologies to one another that really is an indictment on civilized societies. So having said those provoking words, I'll address your question. The 3 policy topics are access, affordability, and transparency. We really need to look at policies that improve access to care. That kind of goes without saying. Affordability, I think, is a lot more nuanced in the US, especially, but I think carries over to other health systems around the world, because inevitably the cost to patient is significant at one level or another. The cash register may not be The till may not be at the pharmacy or chemist counter the way it is in the US. Interestingly, the pharmacy is the only place in the healthcare system that if you don't pay money, you don't get care. You literally have to pay the pharmacist before you get your medicine in the US. And then transparency, because there are an awful lot of components of our healthcare system or healthcare systems in general that lack transparency, that put patients especially in the dark, and that are the kind of dark drivers of a lot of these challenges that impact patients and access to care, things like pharmacy benefit managers. There's an entire Fortune 5, not Fortune 500, Fortune 5 companies like Express Scripts and Optum in the US that no one's ever heard of, that doesn't exist except in the middle of the transaction for people's pharmacy benefits, that are making billions of dollars off the backs of the healthcare system, that are cloaked in secrecy. And so we need more policies that address that transparency. We definitely need to look at policies that address the affordability in general. Why a hospital visit, isn't computed at the same level or index as, say, a therapy or medicine. And then that general access policy where, just comes back to that whole concept that we got to start acting like first world countries if we are first world countries. And that means we have to give our populations proper access to general, basic, primary care. Another vision of mine, the United States has an untold number of thousands of post offices run by the federal government in every damn town in this country that are essentially these cathedrals to a bygone era, right? When we had Pony Express and such. Well, what a perfect institution to co-opt into a future healthcare system that could make primary care something that's accessible and available to literally every citizen, because all of us live, whether you're rural or urban, near a post office. But again, that's a little bit more on the visionary side, but speaks to kind of the direction we see the healthcare system, the curve bending in favor of patients.
Yeah, well, this hour has gone very fast, but I've got one last question before I introduce next week's session. And it's, if I came back in 10 years, Seth, what would the last 10 years look like for you in this field? So Teddy is now 15,
Yeah.
all right?
Well,
so what have you done in the last decade? Because you would now be 35 years in GHLF.
Yeah, well, apart from my joke of running, I own and operate a 5-star all-inclusive resort for my kids. I'd say they, I think for GHLF and specific to the work we do, we better remain in the vanguard of that technological solution set for some of these gigantic challenges that only technology can solve for. Yeah, a little bit of political will. Yeah, a little bit of cultural evolution, and a whole lot of other disruptive external factors like this pandemic we just went through or are going through still, for us to reflect back on the future next past 10 years, however we say it, as being pivotal for GHLF driving those solutions forward in concert with all of our amazing partners. So many of you here gathered today, certainly IFA and countless others, who together, none of us are as strong as all of us. And that gives us that hope that these next 25 years, because that's how I think now, these next 25 years will make for lots of development. And by then I hope, let's see, 65 ought to be the new 25, right? That's my hope.
Yeah. Okay. Well, look, stay there just for a moment, Seth, while I introduce our next week's expert. Thank you, Luana. And we're going to be in conversation with an expert, Dr. Andrew Sixsmith, on the future of age tech. So Andrew was not able to be with us a couple of weeks ago, but he returns. So please join with us in a conversation with Andrew. He was the principal investigator and co-lead for Age Well, which is a national centre of excellence in Canada. So join with us then. So thank you. You know, Seth, I just want to play back to our cafe attendees some of the things that I've pulled out. One of the keys are the relationship with your condition. And I think it goes beyond that. It's the relationship with yourself and your own health and well-being and taking part responsibility. I think you talked a lot about, you know, patient-reported outcomes that are being logged and this important sort of venture, you know, that for the first time ever, there could be this real life conversation between, you know, your consultant, your doctor, the nurse and yourself. You really talked about exporting our brand of advocacy. And I think that's a really important aspect. There is a brand of advocacy that GHLF has that we want to buy into. So I encourage everyone, you know, to learn more about creaky joints and about GHLF. You also asked us to lean in. And I think this is, you know, a catchphrase, you know, lean in, do it, not talk about it. You know, I think you also talked about this word stickiness that we sit in on a daily basis. And stickiness can be being stuck, or it can be giving us traction to move forward. Access, affordability, transparency, and more of us going forward together. So, Seth, you will have the final last word in this very important session, where this session, this day and tomorrow and the next day really matter. So please, Seth.
Make it happen, right? I just dropped into the chat my email address, my colleague Adam's email address. We invite everybody with interest in these topics and others we didn't cover today to reach out. I know I'm not supposed to promote us in that direct way, but I did want to take advantage of this opportunity to say we must work together, we must come together, and we must coalesce together around these important topics. Thanks, Jane. Thanks, IFA. You know, we're here and we look forward to working together, and as importantly, to getting to know you all a little bit better.
And thank you, Seth. Thank you, Seth. And let us celebrate, you know, Kawaldip Samar, you know, former CEO of International Association of Patient Organisation, who we know and care about, you know, in his passing. So our thoughts and prayers and best wishes to his family, friends and colleagues around the world. So be well, my friends, and we'll see you all next week. Thanks, Seth. Say hello to Teddy and his Cheerios. See you later.
All good.